Session 131, the ABCs of thyroid cancer, understanding key terms, concepts, and initial diagnostic and treatment steps with Lindsay A. Bischoff, MD, an endocrinologist. Dr. Bischoff is an associate professor of diabetes, endocrinology, and metabolism, a medical director of the Thyroid Center at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. Dr. Bischoff has a particular interest in the diagnosis and treatment of thyroid nodules, thyroid cancer, and thyroid dysfunction. She's a medical director of the Vanderbilt Thyroid Center, active member of the American Thyroid Association, and is on both the Thyroid Cancer Guidelines Committee of the National Comprehensive Cancer Network and the ATA. Dr. Bischoff completed her residency in internal medicine and an endocrine fellowship at Thomas Jefferson University Hospital in Philadelphia before joining the Vanderbilt University Medical Center. She was an active member of the teaching faculty as an assistant professor at Sidney Kimball Medical College at Thomas Jefferson University. Before we start, if you have questions, Dr. Bischoff has indicated that she can answer questions that you may have during the webinar. So please put your questions in the Q&A rather than the chat. If you go to the bottom of your screen, there's a little Q&A that you can type in your question. And 5 minutes before the end, because we get cut off exactly at the hour. So 5 minutes before the end, we'll be doing the final wrap up. Okay, Dr. Bischoff, thank you very much.
Thank you, Patty. And thank you all for having me speak today. I'm really happy to be here. I think patient education is so crucial in all diseases, but particularly in thyroid cancer. And so as Patty indicated, please let me know as questions come up. I think it makes sense to answer them kind of as we go along. So my talk today is really going to go over the basics. We're going to talk about nodules, cancer, the diagnosis, the prognosis, and of course the different subtypes. There we go. I don't have any disclosures. Again, just what we'll concentrate on today or this afternoon is reviewing a thyroid nodule. That is sort of the first part of the thyroid cancer journey. Thyroid nodule biopsy, who's biopsied and what does that mean? And treatment, so surgical options, pathology results, prognosis, and therapies. So first, we'll start with thyroid nodules. They're extremely common, as many of you had probably heard or been told when you first saw your endocrinologist. Half of the population has them by ultrasound, and the majority of those are benign, 95%. Of course, 5% are thyroid cancer, and it's crucial that we identify clinically relevant thyroid cancer, but also avoid unnecessary intervention in the rest of the population. And so the way we have evaluated thyroid nodules has really evolved over time, where we initially had biopsied all nodules. Then we moved to looking at single features of ultrasound patterns. Then we looked at these patterns and composite features where we tried to assess, well, if you have this appearance of a nodule and this appearance of a nodule, then maybe we biopsy it. And now we're moving toward a little bit more elegant assessment where we look at a composite of multiple features and do fewer biopsies with a higher yield of malignancy. So just to illustrate that point, here are the 2006 ATA guidelines. The question here was not whether or not a nodule should be biopsied, but it was whether or not to do it under ultrasound guidance or by palpation. And so it just reminds us that we've come a long way from that in evaluating thyroid nodules. Here are the 2009 guidelines. And this, I'm just gonna, sorry, put this screen down here. This was when we started to define differences in nodules, where nodules might look more benign or more concerning. At this point, we were really looking at a certain specific single feature, whether or not it was dark on grayscale or lighter on grayscale, to dictate at what point a nodule would be biopsied. Then we moved to the 2015 ATA thyroid cancer guidelines, which is the most recent ATA published nodule guidelines. It included both nodules and cancer. And this was an atlas where we would match a nodule of a patient to one of these pictures to look at sort of the appearance of a nodule and risk for malignancy. And we had different cutoffs out of these 5 appearances. We had high suspicion, intermediate suspicion, low suspicion, very low suspicion, and benign. And so we were starting to not biopsy very benign lesions, but we're still had some difficulty determining which nodules should be biopsied when. This slide gives us the predicted malignancy rate for each nodule. So a high suspicion nodule, the thought was that it would be very likely to be malignant, 70 to 90%, whereas a low suspicion nodule was 5 to 10%, and a very low suspicion nodule was less than 3%. And those are the nodules that were not biopsied. In 2017, the American College of Radiology came out with their first guideline for thyroid nodule biopsies. And this was a new approach where each nodule was evaluated by looking at 5 different features. We look at the composition. Was the nodule solid? Was it cystic? Was it a mixture of both? The echogenicity is really referring to the grayscale of that nodule in comparison to the background tissue. Hypoechoic indicates it's very dark. Hyperechoic indicates it's lighter. Shape, if a nodule is wider than tall, that indicates sort of a benign growth pattern. It's growing within the tissue planes. Taller than wide is a more aggressive growth pattern, growing against the tissue planes. And so you see there's 3 points. More suspicious features get higher points for taller than wide, whereas there's no points for wider than tall. We also look at the margins of the nodule. Are the margins smooth? Are they irregular? Does the nodule poke out of the thyroid gland? And the echogenic foci. So this is really talking about calcifications, and different types of calcifications have different sort of risks of malignancy. And so each nodule is evaluated by looking at all 5 of these characteristics, and the points are added up for each nodule. And depending on the number of points, the nodule is labeled a TI-RADS 1 through 5. And so this is just to illustrate that we've gotten much more methodical about what nodules to biopsy and at what size. So then based on the size, a more suspicious nodule, for example, a TI-RADS 5, would be biopsied if it's greater than 1 centimeter. Whereas a non-suspicious nodule, which are 1s and 2s, these are generally cysts, we wouldn't biopsy. 3s and 4s tend to be our run-of-the-mill thyroid nodules. And 3 is a little bit less suspicious than a 4. And so a 3 we biopsy if it's greater than 2.5 centimeters, and a 4 greater than 1.5 centimeters. They also gave some recommendations for follow-up ultrasound, although I'll say that is based on very little data. The biopsy recommendations are based on some robust data. And so the predicted malignancy rates for the TI-RADS, which again is 5 different categories, just like the ATA, was much lower than the predicted ATA malignancy rate. And so TI-RADS 5 nodules, which are our most suspicious, about 20% of those are malignant and 80% are benign. And this is just a nicer way to be able to calculate the likelihood a nodule is going to be cancerous and help guide biopsy. And so the ATA is currently back at the drawing board, and they are working on the next iteration of thyroid nodule biopsy recommendations, which due to the complexity has now been separated from the thyroid cancer guidelines, which I think is a good thing. And the idea is that the ATA will be able to have a system that classifies all nodules. About 15% of nodules were not classifiable by their older guidelines. So you've had a nodule, the nodule was biopsied. What's the result? And of course, in a perfect world, you'd have one of two results. It would either be benign or it would be malignant. And as many of you may have experienced, that is not always the case. And so we have another system that we number called the Bethesda classification. And so this is a system where we look under the microscope at thyroid cells from a biopsy. So this is different than surgical pathology. These are cells that were taken by a needle. And based on the appearance of those cells, the nodule or the cells might be diagnosed as indeterminate. So in this classification, a Bethesda 1 is non-diagnostic. And that means when they did the biopsy, they just didn't get enough cells. And so there's just no information. A Bethesda 2 is benign, and a Bethesda 6 is cancer. So 3, 4, and 5 between benign and malignant are all indeterminate. Each one has a different appearance and has a different risk for malignancy, with the Bethesda 5 being most suspicious, and that has up to an 80% chance of thyroid cancer. And so we typically lump that with Bethesda 6, and we call that cancer and recommend surgery. 3s and 4s, we tend to not rush patients to surgery because we want to be certain that the surgical approach is the right one for that patient. And so a Bethesda 3, which is probably our most common indeterminate result, has about a 15% risk of malignancy, and a Bethesda 4, suspicious for neoplasm, has a 30% risk of malignancy. And so in these situations, we often will try to get a little bit more information, and that often includes molecular testing. So for Bethesda 3 and 4, often that requires a repeat biopsy. Some institutions will take an extra sample on the first biopsy, and so they won't need to do a repeat biopsy to send for the sample. Often patients are brought back, another biopsy is performed so that an extra sample can be taken in the event that it's again indeterminate, and so that there's sample to be sent to the molecular testing places. So generally, we would only follow a Bethesda 3 with ultrasound, and a Bethesda 4, we wouldn't typically do that. But again, the importance of joint decision-making with the patient, depending on the risk benefit to each individual patient from a watchful waiting standpoint or a surgical standpoint, is really key. Sometimes we move forward with a diagnostic lobectomy, a partial thyroidectomy for Bethesda 4, less commonly off the bat for Bethesda 3. Just a brief note, because this could be a whole 2 hours in and of itself, on molecular testing for indeterminate thyroid nodules. There are 3 commercially available groups that do this. There's ThyroSeq, Afirma, and ThyGenix. I have no affiliation with any of them. I have experience using all of them. They all, in a different way, look at multiple genes to assess the risk for malignancy. It is an imperfect system. We don't get a perfect answer every time. Some of them are very helpful to rule in benign disease. Some are helpful to rule in cancer. And the list of genetic assessment continuously gets longer with every update of these tests. And so they are getting better and better. Historically, they didn't perform well with Hürthle cell carcinomas or Hürthle cell lesions, and they are starting to do a better job with that as well. I've listed some common genetic tests or molecular tests that are looked at with all three of these. And some of you may be very familiar with that: BRAF, RAS, TERT, NTRK. Those are helpful to determine if a lesion is cancer. Also, it's helpful to rule out other things. So these nodules are sent for PTH assessment to make sure we're not assessing a parathyroid nodule. RET mutations and calcitonin are helpful to determine if a nodule is medullary thyroid cancer. I think there's a Q&A, so I'm going to pause for just a second. The question is, how does a person get a benign biopsy, have surgery, and tumor results found to be anaplastic thyroid carcinoma? Biopsies are not 100%. The larger the thyroid nodule, the more potential for missing the malignant cells. And so it is possible to have a benign biopsy that really is a cancerous nodule. That's why the appearance of a nodule is so important. Sometimes we see a nodule on ultrasound that has dense microcalcifications, extrathyroidal extension. You know, a benign biopsy doesn't usually make you feel better about that. And so it is important to take that into consideration when you're evaluating a nodule for biopsy. There's another question. Are 4+ centimeter apparently calcified nodules that do not readily give up cells, non-diagnostic for FNA biopsy, typically cancerous or not? That is hard to say. They certainly, my suspicion would be there. It depends on other features of the nodule and what that calcification looks like. Sometimes there's a cystic component that degenerates and forms a chunky macro calcification, and that can make it hard to get cells for biopsy. But certainly repeated non-diagnostic cytology in nodules that are not cystic, nodules that are truly solid, are a concern, and do occasionally push us to doing a diagnostic thyroid lobectomy. Greater than 4 centimeters, the discussion could even be whether or not that should be a total thyroidectomy. Okay, great, good questions. So then the next discussion, after we have a cytology diagnosis that's either cancerous or concerning to be cancerous, then the question is, what type of surgery? Because the treatment for thyroid cancer overall is surgical resection. And so, again, this is something that we've changed historically. We used to do total thyroidectomies on everyone, and now we are being more selective in patients that have total thyroidectomies or partial thyroidectomies. So as you probably all know, the thyroid gland looks like a butterfly. And so you can kind of divide it into a right lobe, a left lobe, and then that little bridge that connects the two is called the isthmus. And so a common surgical procedure would be to just remove half of the thyroid gland, leaving the remaining half intact. And that's what we call a lobectomy. The benefits of a lobectomy is it's a lower complication risk. You're under anesthesia for a less amount of time. You are only entering really one part of the neck. And so we are bilateral people. And so we have parathyroid glands on both sides of our neck. We've got 4 of them. We can function totally normally with a half of one. That being said, if you take them all out, you're in trouble. You're going to have hypocalcemia that could be lifelong and really quite significant. If you damage both recurrent laryngeal nerves, that's what helps you sort of speak and swallow. And so that could cause a major morbidity and with a total thyroidectomy. Again, these are not common complications. The more thyroid surgeries a surgeon does, we have data that shows that higher volume surgeons have fewer complications, but there's always a risk whenever you have surgery of any kind. And so a lobectomy decreases the risk of those complications because you're only entering that one part of the neck. It's possible that you wouldn't need thyroid hormone replacement. And this is often a goal for patients to avoid lifelong medicine. And so a partial thyroidectomy or a lobectomy gives a chance at that. There are some downsides of a lobectomy, needing a second surgery. We often don't know the details of the tumor until several days after the surgery due to processing of pathology and stains and things like that. And so sometimes if it's high risk and you need to facilitate radioiodine or have other concerns, then a completion thyroidectomy, which would be a second surgery, is done. And you lack a reliable tumor marker, and I'll get to that later in the talk, when you have part of your thyroid gland still intact. Total thyroidectomies, again, higher complication rates. Always you're going to need lifelong thyroid hormone in that situation, but you do have a reliable tumor marker. And if further therapy like radioiodine is necessary, then you're all ready for that. And I'm going to pause a second.
We have another question about
Yes.
parathyroid.
Is preserving parathyroids typical for lobectomy or total thyroid removal? So the goal of the surgeons is always to preserve parathyroid glands. They are about the size of a grain of rice each, and they sit typically, although we are all a little different, they sit typically at the both upper and both lower poles of that thyroid gland. And because they're so small and because they can actually be embedded in the thyroid gland itself, parathyroid removal is a risk whenever you're taking out thyroid tissue. It's not the goal, but it happens quite frequently. If you take out half a thyroid, the worst case scenario is you're going to take out 2 parathyroid glands. And if you take 2 parathyroid glands, you've got 2 remaining and they will function normally. If you take out the whole thyroid gland, ideally, you'll still have your parathyroid glands left. But if all 4 are damaged or removed, that's when there's a problem with the calcium issue. Good question. Okay. So what about neck dissections? Some of you may have heard about taking lymph nodes out of the neck, and some people have lymph nodes removed and others don't. And why is that? So for papillary and follicular thyroid carcinoma, we've moved away from, again, just because we want to make sure we're doing just right surgery, not unnecessarily too much surgery and not enough surgery. And so we've typically moved away from what we call prophylactic neck dissections. And what that is when you're doing a thyroidectomy for thyroid cancer, and prior to surgery on your imaging, there's no concern for abnormal lymph nodes or other disease. When the surgeon operates, she or he doesn't see any concern of spread of that tumor outside of the thyroid gland, and no concerns for lymph nodes that have cancer in them. So in that situation, the surgeon would not typically take out lymph nodes because, again, it increases risk of surgical morbidity, nerve damage, and parathyroid damage. That's different than a therapeutic lymph node dissection, which means prior to surgery on imaging, there were abnormal lymph nodes that were concerning for malignancy. Whether or not it was biopsied or not, they had concerning appearance. Or if the surgeon opened the patient up and saw concerning lymph nodes with their eyes, that is no longer a prophylactic neck dissection. That is a therapeutic neck dissection and should absolutely be done. And so that's true for papillary and follicular. For medullary thyroid carcinoma, we do typically recommend a central neck prophylactic neck dissection. And so this picture shows the different levels. We have compartments in our neck that the surgeons have divided up to help guide which areas should be operated on at what time. And so this central part is called the central neck, or level 6. And this is where the majority of neck dissections will occur. And that's where thyroid cancer tends to spread first. It can certainly spread to the lateral neck. And that's the sides here, 2, 3, 4, and 5. And the surgeon would never go in there prophylactically, meaning without knowing that without any concern that there's disease there. But that's a common area for thyroid cancer to spread. And so when the surgeon operates, then the surgery will be extended to the side of the neck, usually on the same side of the tumor, but occasionally with aggressive disease, it would have to be on both sides. Okay. Question. Is a right lobectomy and left lobectomy considered a total thyroidectomy? Yes. So we sometimes call it a two-step thyroidectomy, where you have half your thyroid gland removed, and then for whatever reason, you have you have the other side removed. And that could be, you had half of it removed 1 billion years ago for a benign nodule, and now you have an issue and they're completing it. Another common scenario would be, it was chosen to do a lobectomy due to the predicted low risk thyroid cancer outcome. But then under the microscope, the pathologist says this is not low risk for recurrent thyroid cancer, and this patient, you know, has higher risk and needs radioiodine. Then the second half would come out. And so that's called a completion thyroidectomy, or a two-step. So yes, if you take out both halves, it's a total. Okay, so that leads us to what's under the microscope. So what about the surgical pathology? So we've talked about the cellular pathology from a biopsy, but what about the surgical pathology? And this is really where the important information is. And so this is a cartoon drawing of thyroid tissue. And so thyroid tissue is organized into follicles. This sort of gelatinous goo in the center of the follicle is colloid. There's not cells there. That's where thyroid hormone is stored. But surrounding this colloid are follicular cells. These follicular cells are where papillary thyroid carcinoma and follicular carcinoma arise. So the vast majority of thyroid cancer comes from these cells. In between these follicles are parafollicular, or C cells. This is where medullary thyroid carcinoma arises. They're two totally different cell lines, totally different behaviors. And so we'll talk about them separately. This is a histopathology slide showing the same thing, just in more real life. Here's that colloid, and this follicular epithelium are the follicular cells, just a single cell line that lines the follicle. And then we've got the parafollicular cells in between. So where do the problems occur? Follicular cells, this is where thyroid function problems happen. So your follicular cells make thyroid hormone. And so if someone has thyroid dysfunction, it's because of an issue in the follicular cells. And as I said, this is the area where papillary, follicular, poorly differentiated, and anaplastic thyroid cancers arise. The parafollicular, or C cells, are where the medullary thyroid cancer arises. Parafollicular cells don't do a whole lot. They secrete calcitonin, which is not physiologically useful in humans, but it's overproduced in medullary thyroid cancer, making it an excellent tumor marker. Just of note, some species like salmon, their calcitonin actually inhibits bone resorption. So sometimes some species have functional calcitonin, but we do not. So when you have a thyroidectomy, we replace thyroid hormone, but we don't replace calcitonin. Again, functional units of the thyroid are those follicular cells. And follicularly derived thyroid cancer, which is papillary, follicular, anaplastic, and of course, poorly differentiated, all arise from here. This is the lion's share of thyroid cancer. And out of that, 85% is papillary thyroid cancer, 12% is follicular thyroid cancer, and 3% is anaplastic thyroid cancer. Parafollicular C cells are where medullary thyroid cancer comes from, and this is only 1 to 2% of all thyroid cancer. Treatment of differentiated thyroid cancer, so this is specifically non-anaplastic, is surgery. What type of surgery? We kind of discussed: lobectomy, total thyroidectomy, and lymph node dissection. So lobectomy is typically favored when we're able to at least to a degree, predict that it's going to be low risk. And so typically we would offer a lobectomy if the nodule in question was less than 4 centimeters. If the other side of the thyroid gland didn't have any nodules, or had maybe some very benign appearing cysts. If the tumor had no visible extension outside of the thyroid gland and there were no concerning lymph nodes. If that's not the case, we recommend a total thyroidectomy. So if there's nodules on both sides, certainly if there's suspicious nodules on both sides, if the tumor is very large, 4 centimeters or greater is the cutoff that most institutions are using. If there's concerning lymph nodes on imaging, or certainly if the tumor looks like it's extending outside of the thyroid gland, because that would indicate that the likelihood of needing radioiodine is high. And you can't do that when you have half a thyroid gland. You cannot give radioiodine with an intact thyroid lobe. And so in that situation, we recommend a total thyroidectomy. To answer an earlier question, completion thyroidectomy, that's that 2-step or taking the second half out after you've already taken the first for higher risk malignancy. Staging. So when we hear the word cancer, which no one ever wants to hear, we often then start thinking of staging. What stage am I? For the majority of thyroid cancer, staging is less helpful than assessment for recurrence. And the reason for that is staging is specifically a risk stratifier for dying from thyroid cancer. It's a mortality risk stratifier. And thankfully, the majority, certainly not all, but the majority of thyroid cancer has a very low risk for mortality. And so even aggressive tumors may be stage 1, meaning the patient won't die from this thyroid cancer, but it doesn't mean that it's not a higher risk thyroid cancer in terms of likelihood of coming back or the morbidity that it could cause. There are a few staging systems that are used. The most common is the AJCC TNM staging, and so that's the tumor node metastases staging. This is what the American Thyroid Association recommends, and I think most institutions use this. Other staging systems include the MACIS and the National Thyroid Cancer Treatment Cooperative Study. They're all sort of variations on a similar theme where they look at the metastases, they look at the size of the tumor, they look at the age, but there are certainly some differences. And as with everything else, we keep updating this to try to make it more and more accurate and more relevant for our patients and clinicians. And so in 2018, the 8th edition of the AJCC TNM staging system was published. And this is specifically for differentiated thyroid cancer. So this would be non-medullary, follicular, and papillary, and often really poorly differentiated, although that is a tougher conversation because of the variability and within that group. The important thing to note that was new in the 8th edition was the change in the age cutoff. And so what we know is that when patients are diagnosed with papillary or follicular thyroid carcinoma at a younger age, their risk of dying from that cancer is significantly lower. And so we used to use 45 years as a cutoff. We bumped that up to 55 years. And so if a patient is diagnosed at age 55 less than 55 years of age, the highest stage that they can attain is stage 2. And that's in the setting of distant metastases. So just to walk you through this, T is tumor, N is node, referring to lymph nodes, and M is distant metastases outside of the neck. And so any T means any size tumor. Any N means any amount of lymph node metastases in the neck, but no distant metastases. Those patients are all stage 1. And that translates to a 98 to 100% survival. If that patient has distant metastases, the most common place for thyroid cancer to spread are the lungs, followed by bone. Survival is 85 to 95%. And so this is just to illustrate that it's a disease that most of us will not die from, but it doesn't mean that it's not going to be problematic. And so this is not as useful of a conversation as recurrence risk. Age 55, these numbers change a bit. However, overall stay very reassuring and very, very good. When patients have a lot of extension of their tumor and distant metastases when they're older, that is where we see an increase in mortality risk. Anaplastic uses the same staging system, but there's no age cutoff, and all patients are stage 4 to varying degrees. So what's more helpful to discuss thyroid cancer with other clinicians and with our patients is the risk for recurrence. And so this was last updated by the 2015 American Thyroid Association guidelines, and we're working on updating it again now. And we categorize people into 3 categories based on that initial surgical pathology. And so we look at the tumor size, we look at if there's an aggressive subtype, we look at blood vessel invasion, we look at lymph nodes, how many lymph nodes, how big were the lymph node metastases. We look at if the tumor extended into tissues outside of the thyroid gland, and we try to predict the likelihood of thyroid cancer coming back, which typically looks like lymph node recurrence in the neck. That's what typical recurrence looks like. And so it's pretty clear who's high risk, and it's pretty clear who's low risk. And if you're not high risk and you're not low risk, you kind of get shoved into this intermediate risk for recurrence, which is a really variable group. So for low risk patients, these patients have tumors that are less than 4 centimeters and remain inside of the thyroid gland without any blood vessel invasion or invasion into surrounding tissues. We found that you could have lymph node metastases in very small volume and not have recurrence, be low risk. And so, to extrapolate, to sort of apply the data to guidelines, we want to make things sort of a little safer. And so where the data was saying about 7 millimeter lymph nodes in the central neck, we changed that down to 2 millimeters because we want to make sure that we're not being cavalier and not giving radioiodine to patients who would potentially benefit. And so if there are 5 lymph nodes that have tiny, we call them micrometastases, so 2 millimeters or less, those patients are still considered low risk for recurrence. For follicular thyroid carcinoma, minimally invasive follicular thyroid cancer is also considered low risk. So this would be minimal capsular invasion or minor vascular invasion. For our high-risk patients, if there's large lymph node metastases, 3 centimeters or greater, it's quite large. Certainly if there's distant metastases, if there's gross extension of the tumor outside of the thyroid gland, or if it wasn't completely resected, there's a lot of blood vessel invasion in a follicular carcinoma. Those are considered high risk. And frankly, everyone else is intermediate risk. Oh, I have a question.
Yeah, there's that question about BRAF.
So that's a $1 million question. Does BRAF V600E play a role in initial risk assessment? There's a lot of debate there. And I don't think that the data is really there to answer. There are people that feel strongly on both sides of the coin. There are some people that feel that BRAF testing, if positive, should warrant a total thyroidectomy instead of a partial thyroidectomy. The data there is lacking. And in fact, it's so lacking, and we just reviewed this at our carcinoma guidelines, the ATA guidelines, that we're not recommending routine BRAF assessment preoperatively or even postoperatively because we just don't know what to do with it. But great question. Another question, what if the cancer spreads to 17 lymph nodes? So it would definitely not be low risk, but it could be intermediate or high risk depending on the size and location of those lymph nodes. Often we'll see 17 out of 35 lymph nodes, and they're all, sub-centimeter or certainly less than 3 centimeters. And those patients would fall into the intermediate risk for recurrence. Okay. So what do those risks for recurrence mean? What are you telling me? So low risk for recurrence seems to have about a 3% lifetime risk for recurrence. And radioiodine therapy did not reduce the risk for recurring. And so as we'll get to a future slide, we no longer recommend it routinely for our low risk patients. Intermediate risk, there's data that indicates 21%. Admittedly, it's so variable. It's really hard to pin down a percentage. But we know high risk has a 68 to 80% risk for recurrence. And so those patients, we definitely want to help reduce the risk if we can. And again, with papillary and follicular, that would be via radioiodine. It is important to note that this risk stratification is dynamic, meaning it continuously changes. So if someone has high risk for recurrence disease right off the bat, it doesn't mean that they're going to be high risk their whole lives. So most recurrence happens in the first 3 years after initial treatment with thyroidectomy. And as years go by, each year that risk for recurrence gets lower and lower. And so, if it's been many years, it's very possible for someone who initially started as high risk for recurrence to eventually become low risk for recurrence. So it should just be reevaluated at each visit and looking at the parameters that we use to monitor for recurrence. So who gets radioiodine? Well, first we need to remember what the goals of radioiodine are. And the most common reason to give radioiodine is to reduce the risk for thyroid cancer recurrence. We often can use it to achieve an undetectable thyroglobulin in patients that have biochemical disease, meaning we can follow the thyroglobulin, but we don't see any disease on imaging. If someone has low risk disease but has a significant amount of thyroid tissue, sometimes radioiodine is given for that, and to treat distant metastases that are iodine avid. Occasionally, there's a decrease in mortality risk as well. I'm going to start going a little bit faster because I'm looking at my time. So the people that benefit from radioiodine are really the high-risk patients and many of the intermediate risk patients, but again, we don't recommend it for low risk. We can give radioiodine for small volume nodal disease. So if after surgery you have a lymph node that's 6 millimeters and suspicious and it was biopsied and it's found to be thyroid cancer, radioiodine is a potential therapy for that. Large tumors or large amount of bulky lymph node disease, radioiodine will not be beneficial. And distant metastases that take up iodine. How is thyroid cancer monitored? So 2 things that we look at all the time: thyroglobulin, and that includes a thyroglobulin antibody, and neck ultrasound. So a thyroglobulin is a blood test that detects thyroid tissue. We often say it's a tumor marker, which is actually inaccurate. It's a thyroid cell marker. So if you measured my thyroglobulin, it will be high, not because I have thyroid cancer, but because I have a thyroid gland in my neck. And so if you have a partial thyroidectomy and you still have half a thyroid in your neck, that thyroglobulin is not going to be useful. 20% of the population make antibodies to the thyroglobulin, and that's nothing wrong with those people. It doesn't make their thyroid cancer worse, but it means that the thyroglobulin is less reliable when measured in the blood. And so we've attempted different lab assays to minimize that. Nothing is really perfect. And so that interference seems to continue. So we can use the antibodies themselves to evaluate for recurrence. If antibodies stay stable or decline, that's an excellent indication that thyroid cancer is no longer present. If we see the antibodies really going up, that is a concern for recurrence. Neck ultrasound should include all compartments of the neck, not just the thyroid bed. So if you get an ultrasound, it should be all here to here, both sides of the neck. And it's really important for initial surveillance. as time goes on, if the thyroid globulin and the antibody test are undetectable, ultrasound in addition becomes less helpful. When we talk about how people are doing from thyroid cancer, we use this response to therapy. And I won't get too in the weeds about this, but basically we're looking at the thyroid globulin as a tumor marker to tell us, this is again in patients with total thyroidectomies, to tell us if there's concern for thyroid cancer or not. And in patients that don't have radioiodine because they have low risk disease, they often will have very low positive thyroid globulin because there's microscopic thyroid cells that line that thyroid bed, and we didn't zap it with radioiodine, and that's okay. We can detect thyroid globulin down to 0.1, which is incredibly sensitive. And so we categorize things as sort of excellent biochemical response, meaning the blood work looks great, to indeterminate biochemical response, which means the thyroid globulin is sort of borderline, but nothing that really indicates recurrence. And so we're just watching. Incomplete biochemical response, that's when the thyroid globulin is really grossly elevated, or if there's structural disease seen on imaging. And I have two questions. Can one not have antibodies, but antibodies develop later? If antibodies develop later, that should be a concern for recurrent thyroid cancer, and it would trigger at least starting with an ultrasound. Is cellular pathology typically done during surgery or only after FNA? I'm not quite sure how to answer that, what that question. If you don't mind retyping it, I'll come back to it. Please explain no TSH suppression. Yes, let's get to that. I'm going to get there. Let's do whole body imaging. It's good for picking up distant metastases for iodine avid thyroid cancer. It's generally used with neck imaging because neck imaging tends to be a little bit better at picking up small volume disease than whole body imaging in the neck. And usually we do iodine scans if the thyroid globulin is high, but the neck imaging is clear. And so we want to see where the tumor is. Sometimes that's used with radioiodine, for example, after radioiodine therapy, or sometimes it's used alone as a scan. And PET scans are less helpful for most thyroid cancer. If the thyroid cancer is found to be iodine inavid, meaning those cells don't take up iodine anymore, then we do sometimes do PET scan to help determine location of disease. How much thyroid hormone do I need after surgery? And so the appropriate amount is crucial. We don't want people to have too much because it can impact their bone health over time. And we don't want you to have not enough because that could increase your risk for recurrence. And so there's a calculation we do for a goal of TSH suppression or no suppression. TSH suppression is a higher dose, and we do that to with the goal of decreasing risk for recurrence. And so in our higher and intermediate risk for recurrence patients, we overtreat them a little bit for at least 2 years to help suppress the growth of thyroid cells and reduce the risk for recurrence. For our low risk patients or patients who have that excellent biochemical response and have been a few years out from their surgery, even if they had previously been, a higher or intermediate risk, we then target a high normal thyroid hormone, so a low normal TSH. And so that's a little bit of a lower dose. To explain the high normal thyroid hormone and the low normal TSH, we have to remember that TSH is thyroid stimulating hormone. It comes from the brain and tells the thyroid gland to make more or less thyroid hormone. Doesn't know your thyroid gland is not there. And so it's a way that we can test the amount of thyroid hormone based on your dose. And so a common normal range is 0.45 to 4.5. If we want you to be overtreated, that TSH goal is going to be down here, usually less than 0.5 down to 0.1. And so you can imagine if your brain senses, I have too much thyroid hormone, it'll stop or decrease sending that TSH signal. So a low TSH, high thyroid hormone. And that's often the goal initially after surgery, particularly for our higher risk patients. For our lower risk patients, we tend to target a low normal TSH, so 0.45 to about 1.9. And so this is sort of what I just said. Again, I'm just trying to be mindful of the time. 2 questions. Is it true that 5 years of TSH suppression can cause heart issues? The duration of TSH suppression doesn't correlate with heart issues, but it does correlate with bone loss. And so long-term TSH suppression can increase your risk of osteoporosis. Cardiac issues can occur typically in older patients, but doesn't have to be due to long-term TSH suppression. It can be just initial TSH suppression, which increases the risk of atrial fibrillation. I've had 5 dose changes and still can't get under 2.4 TSH level. I've read brand versus generic. So brand and generic at this point are considered equivalent in terms of their therapy, I would say. So this is sort of in a kind of the questions that were asked are sort of part of this. So that's good. You have to weigh the risks and benefits of over treatment with AFib and bone disease and the thyroid cancer status. I'm going to get to some of these questions actually. I just want to because they're in this. That'll be the last slide on a note on thyroid hormone. Because what I'm wondering about the question that was just asked that you can't get your TSH down, it could be how you're taking your thyroid pill. So let's get to that. I don't want to skip out on medullary because some of you out there might be having medullary thyroid carcinoma, and I don't want to miss that. So 75% of medullary thyroid cancer is sporadic, but other than that, it can be a genetic mutation and a germline mutation. And so it's important to test a RET gene. We'll get to this. A RET gene for all patients that have a diagnosis of medullary thyroid cancer. There are greater than 100 RET mutations, and some of them are very helpful in predicting timing for prophylactic removal of the thyroid in affected family members. So if you have medullary thyroid cancer and you're RET positive, it's important for siblings or offspring to be tested as well. And people that are positive, we recommend the removal of the thyroid gland prior to getting medullary thyroid cancer. And so depending on the gene mutation, that can be a guide. We're going to just skip this. Again, surgery is the primary treatment. The calcitonin helps dictate how aggressive to be with scans. If the calcitonin is less than 150, there's not going to be any disease outside of the neck. But once it's greater than 150, we do start doing other imaging, CAT scans, MRI, bone and liver. This says 500 because that's a pre-op calcitonin. 150 is for a post-operative calcitonin. Again, PET is not very helpful for medullary thyroid carcinoma. Thyroid hormone replacement, there's no role for TSH suppression in patients with medullary thyroid carcinoma because it's a different cell line. It doesn't even see TSH, so it's not helpful. That's the same with radioiodine. Sometimes we do systemic therapy, chemotherapy, beam radiation, but radioiodine isn't helpful because those cells don't take up iodine. We monitor the calcitonin doubling time. That's really the key for medullary thyroid cancer. How quickly does the calcitonin double? And again, if the calcitonin goes from 2 to 4, that's doubling. It's so low, it's not concerning. But over time with these higher numbers, we want to see how rapidly does it double. And if it's slower than 24 months, it's an outstanding prognosis. There's 100% survival at 10 years. When it's faster, 6 to 12 month prognosis, 6 to 12 month doubling time, then it's a much poorer prognosis. And so every time we check a calcitonin, we recalculate that doubling time. I think this is it's probably better to go to, and I'm happy to go back if someone wants me to with the medullary, but I wanted to make a word on thyroid hormone because this is really important for everyone that's had their thyroid removed. Synthetic thyroid hormone is preferred. And so the natural forms of thyroid hormone, Nature-Throid, West-Throid, Armour Thyroid, are pig-derived thyroid hormone that is pill to pill to pill, very inaccurate in terms of its dosing. Synthetic thyroid hormone, which is levothyroxine, some brand names are Synthroid, Levoxyl, Tirosint, are very precise in terms of the dosing. And so it's much more helpful when you're trying to control a specific range to be on something that's very precise. But how someone takes thyroid hormone is really key, because that thyroid pill likes to stick to things in your stomach and not get absorbed. So the best way to take it is first thing in the morning on an empty stomach. The hour on the clock doesn't matter. It could be 6 a.m. one day or 10 a.m. the next, because it lasts in your system for 7 days. You're not going to be running out. But it's because your stomach should be empty. Wait a minimum of 30 minutes before you have anything that's not water. That includes black coffee, that includes tea, food, juice, only water for 30 minutes. After 30 minutes, you can eat or drink whatever you like, but you should not have any vitamins for a minimum of 4 hours. Specifically, it's calcium, iron, magnesium. A multivitamin is going to have at least one of those in there, because that sticks to the thyroid pill really tightly. Some other potential reasons for dose changes, weight change. So if someone has a significant weight increase or decrease, they might need thyroid hormone adjustments because it's in part weight-based. Medication effects, so some anticonvulsant medications, certainly some checkpoint inhibitors on chemotherapy, and commonly oral estrogen that impacts thyroid hormone needs. So it's important to tell your doctor if you've started one of those, because you should have your TSH repeated in about 6 to 8 weeks to see if you need a dose adjustment. If you have absorption problems, that can be an issue. Tirosint brand is a little different than the others. It's a capsule and it's absorbed farther down in your gut, and can sometimes be really well absorbed in patients that aren't absorbing Synthroid, levothyroxine, or Levoxyl. And certainly pregnancy increases thyroid hormone needs, and thyroid hormone levels need to be monitored really closely during pregnancy. So I'm sorry for rushing through at the end. I'm just going to quickly look at, I just had my thyroidectomy in 9 weeks ago, followed by RAI. Is it possible for thyroid cancer to return since I had a full thyroidectomy? Yes, the risk for recurrence is there. Again, typically it would be in the lymph nodes. The radioiodine will work for 6 months. And so it takes time before you can reassess your tumor marker, your thyroglobulin, to see where you are. Next question, is it true that, okay, we answered that one. Is it unusual for lymph nodes to show thyroid cancer after 2 neck dissections and radioactive iodine just 4 months prior? That would indicate a more aggressive disease. And so it would be important to have one really good surgery. You don't want surgery should not be berry picking. They should go in and take out many lymph nodes in that whole compartment, not 1 or 2 or 3. And so that's important. And then making sure that there's close imaging follow-up would also be important. But sometimes we see that more aggressive behavior, and it just needs to be monitored much more closely. 2 more minutes. I have a few other questions. Can I donate blood if I had radioiodine? Not for at least 6 months. So no words on food containing iron. Correct. It's really vitamins. So you can eat, steak, you can drink milk, you can have anything that has calcium, iron, magnesium in it in foods 30 minutes later at minimum, but you should not take the supplement form. Any other questions? Again, I'm so sorry for rushing through. I just was running out of time. Each year of no recurrence after surgery, does our rate of recurrence go down, and by how much papillary? The answer is yes. We don't have data to tell you, in terms of what percentage each year. It's not linear. The first 3 years are a little bit more stable because the risk goes down each year, but not quite as dramatically. After 3 years, there's a big drop off. But yes, every year that goes by that you don't have recurrence, the risk continues to go down. Another question, how do you know if an ultrasound is done efficiently? Is it possible they can miss some cancer in the nodes? Absolutely. And so I would say to be your own advocate, and this is true even in my own institution. I've got certain places that I really make people go to for ultrasound, because it's only as good as the tech putting the probe on your neck. It's not like CAT scan where it's all protocoled. And so when you're going for your ultrasound, make sure that they do an ultrasound from the side of your neck to the other side of your neck. It is not just over where your thyroid used to live, because that's only giving you a very small part of the information. So it should be a complete neck ultrasound. Really important thing. I think probably the most important take home point in terms of how you can be your own advocate.
Okay, this is going to be a wrap. I think we'd like to thank Dr. Bischoff. There's never enough time when something's really interesting.
Thank you so much. Take care. Bye-bye.
Okay, thank you.